Hi, it's Rob Arnfield speaking to you again, and welcome to another module within the Institute's section on point of care echo. And today we're going to talk about stroke volume determination at the point of care. Determination of stroke volume really is the essential advanced technique, if there was to be one, for point of care echocardiographers. It's considered advanced because, as you'll see, we rely on quantitative spectral Doppler techniques, which are not routinely part of the curriculum for most providers, especially in the emergency department or in the ICU. That said, this technique really starts to unlock the hemodynamic understanding of echocardiography and really is a super adjunct to your assessment of left ventricular function in particular, as we will see. If you've heard me speak or seen the module on basic echocardiography, you'll know that the eyeball method of left ventricular function assessment has been tried and true. Gross assessment of ventricular function without having to use calipers or quantitative methods is a really fast and reliable way of categorizing ventricular function that helps with clinical decision making. Getting caught up in the weeds of ejection fraction is generally not that important for acute care decisions that center around vasoactive medications or IV fluid administration. And you'll hear me say that more often than not, and the literature to support this, that both we can do this as non-experts or non-traditional users and should be doing this, is littered throughout both the conventional literature as well as society guidelines, as well as general practice as it's evolved in acute care settings over the past 10 to 15 years. However, occasionally we may wish to go deeper, and that is what this screencast is about. And this is about determining stroke volume. And as we can see in this parasternal short axis view on the left-hand side of the screen, we have very well preserved LV function in somebody with an irregular heart rate. And while we may be tempted to call this high normal or even hyperdynamic LV function, what's really missing from our understanding of this patient's assessment is really how much blood and oxygen is reaching their tissues. And determining stroke volume or cardiac output will allow us to do that, and it allows us to unmask the discordance that sometimes exists between a reassuring left ventricle appearance in terms of how well it contracts and the reality that even though it contracts well, it may not be actually delivering a lot of blood. And there's many circumstances that highlight this, but none perhaps better than hypovolemia, where a heart may have a 90% ejection fraction on the left side, but as a matter of physiology, the patient is starved for oxygen delivery and cardiac output. So the advantages of determining stroke volume, as alluded to with this example, is the discordance between ejection fraction and stroke volume. There are many situations where the left heart looks good, but in fact it's not doing a great job because it's either underfilled or maybe there's obstructive physiology on the right side. And the other great feature of doing stroke volume is that now when you introduce interventions, whether it's fluid administration or vasoactive medications, you can have a more quantitative, real-time assessment of whether or not your intervention is working. And while one could argue that you could quantify the left ventricular function through an ejection fraction and then follow up on that, that is not what we're interested in as acute care providers. We are interested in delivering oxygen to tissues. And so this is another reason why stroke volume is critical. And I would argue that when people learn stroke volume and think in terms of stroke volume and cardiac output, their understanding of hemodynamics and that sort of leap to an advanced understanding of echocardiography and the power that it can wield for hemodynamics is unlocked, and there's better understanding. By way of basic physiology review, let's remind ourselves that stroke volume is determined by three things: preload, systemic afterload, and the contractility of the heart. Now, of course, we focus on contractility when we use the eyeball method or quantitative methods of looking at left ventricular function, but of course that doesn't consider other factors, including preload and afterload, that influence the stroke volume. We'll come back to these concepts a little later. And of course, cardiac output, we need to remind ourselves, is stroke volume multiplied by the heart rate. And this will come in handy to remember, of course, when we find people with preserved stroke volumes but low heart rates and therefore have low cardiac output, and it gives us strength and justification to intervene on heart rates not infrequently. So stroke volume, we can think of an imaginary kind of construct here that the stroke volume is really a column of blood cells that is leaving the ventricle with each systolic event out of the left ventricular outflow tract and into the systemic circulation. Using this paradigm of a column of blood, we need to dust off some math related to the volume of a column. Because if we can determine the volume of a column that's leaving the ventricle with each systolic event, then we can determine stroke volume. So these things are the same. So the volume of a column or a cylinder is determined by the formula pi r squared multiplied by the height of the column. So pi r squared is the area of the base times the height gives us a volume. And so when you think about then determining where this column's dimensions come from, well, it's going to be the area of the left ventricular outflow tract is going to form the base of the column. And as we'll see in a moment, the height of the column is determined by something called the velocity time integral. So how do we do this on the ground in the frontline fashion with our point of care ultrasound machine? Well, we start at the parasternal long axis, which is ideal because of the axial resolution of the left ventricular outflow tract is very good. And we zoom in on the left ventricular outflow tract. We freeze the image, and we will then navigate frame by frame until we see the aortic valve has just opened and we're in mid-systole to reflect the actual geometry of the heart during the phase of the cardiac cycle we're most interested in. Then by using our calipers, we then measure the leading edge of the left ventricular outflow tract in the near field to that of the far field, being attentive to being exactly perpendicular to the axis of the LVOT and not the axis of the sector above. So once we obtain that measurement, which is the diameter of the LVOT, in this case 2.11 centimeters, helpful hint, most people's LVOT is around 2 centimeters, and we know that the area is pi r squared, then we must take pi and multiply it by half of that distance and square it. In general, the area usually results, because the LVOT diameters are usually 2 centimeters, usually the area results in something around the 3 to 3.5 range centimeters squared. As I'll show you later, and your eyes are starting to glaze over because of the math involved here, that when the machine's calculation software is used correctly, you don't have to do any of this math. You just need to know to measure the diameter of the LVOT and punch it in. So now we have the area of the base of the column or the cylinder that forms our stroke volume. And the next view we need to get is the apical 5-chamber view. 5-chamber because it's parallel. It demonstrates a parallel line of assessment for blood flow leaving the left ventricle. And we can see here the pulse wave Doppler gate that is situated in the LVOT as close as possible to the aortic valve without actually touching the aortic valve. And in so doing, and engaging spectral Doppler, and pulse wave is critical here as opposed to continuous wave. And if you need to review that, please review the Doppler module in this section of the Institute. And pulse wave Doppler will yield a spectral envelope representing the output of blood. Of note, we are looking for shapes below the baseline here that represent flow away from the transducer, and we can choose the most representative example of a spectral envelope if the patient has AFib or your window comes in and out because of positive pressure ventilation, choose the highest quality image, or average several spectral envelopes would be the sort of most rigorous way of determining the height of the column. But in this case, we've chosen this particular envelope, and you can see by tracing it around, so you just basically finger paint your way around and trace the shape of this structure. It yields a number called the velocity time integral, which is measured in centimeters, and is really just the integration of this speed and distance traveled for the red cells leaving the left ventricle. So this now gives us the height of our blood column, and we can integrate that with our area, and that's going to produce a volume. Let's look at this step in particular. Having already looked at how to measure the LVOT, let's look at this step of obtaining a VTI in continuous fashion using a DVR recording. So we have an apical 4 chamber view here. We can note a number of things wrong with this heart, but primarily we're focusing on getting the Doppler plane. We tilt the probe to get the 5th chamber with the aortic valve and the LVOT. We've switched to pulse wave Doppler, PW, and we're placing it just in the LVOT, trying to be as parallel as possible, and you can't always get a complete parallel. And now we see that after engaging the spectral Doppler trace, we are cooking. So we have these output envelopes that are consistent with each systolic phase, and we're choosing this particular envelope here as a representative one. We're going to trace around the spectral envelope, and though somewhat tedious to watch someone do this, you can see that being attentive to being adherent to the lines will minimize over or underestimating our VTI, and you'll see that the machine will generate a number for us here, 13.2. Different than ejection fraction, the VTI is a sort of a emotionless number. We have no emotional attachment to VTI, and we just take it at face value, which is actually quite handy in many ways, and I believe in point of care echo, because it really doesn't mean anything to us. So let's integrate that now with our other findings. As you recall, the area from the LVOT was 3.49 centimeters squared. We now multiply that by 13.2, and that gives us a stroke volume of 46.1 cc's. Now, an average stroke volume for most comers would be around 60 cc's, so this is low, which may have been in keeping with your 2D assessment of that ventricle when it showed up earlier. And then at a heart rate of 85, that gives us a cardiac output of 3.9 liters per minute, which is low, of course, with a normal cardiac output being somewhere between 4.5, 5.5 liters, because average stroke volume of 60 cc's and average heart rate of 60 or 70 would give us a cardiac output around 5 liters. So this is low. It's now, we have a number to go on, and we can now justify interventions that address that stroke volume. In this case, with contractility being an issue, we remember that stroke volume is influenced by preload, afterload, and contractility. We see that the contractility here is insufficient to meet our cardiac output needs. And so if this patient had oliguria or rising lactate or other organ failures related to poor oxygen delivery, initiation of inotropes would probably be the most appropriate next step. Now, this is all maybe a little complicated for if you're new to this, but I hope I can give you some relief with some shortcuts. In general, know that LVOT diameter is invariable. So if you go back and repeat that assessment ever, you don't need to measure the LVOT again because it doesn't change. So we can take that 2.11 centimeters to the bank and keep it as part of our calculations going forward. Or better still, you can just look at the changes in the VTI, because we know the LVOT diameter is invariable. So any change in VTI does therefore represent a change in stroke volume when looking at these things dynamically. So if we went back and looked at the VTI after the initiation of inotropes, we just need to do the VTI without doing the LVOT diameter. And in general, the VTI for the LVOT is typically 18 to 20 centimeters, and that's assuming an LVOT diameter of around 2 centimeters. That will vary if people have enlarged LVOTs or smaller ones, and they will compensate by having either perhaps lower VTIs or higher VTIs. But again, the assumption is 18 to 20 as a quick screen. If you're just doing the VTI, should be reassuring. So let's look at an example here for a patient in the ICU who has vasopressor-dependent shock. Parasternal short axis view here shows a on-axis papillary muscle view with no significant pericardial fluid. The right heart does not appear to be terrifically enlarged, and we see that contraction is homogeneous. But for somebody in shock, it's a little sluggish. It's not certainly not the worst any of us have seen, but it looks just a little kind of maybe low normal or mildly depressed to my eye, and that's just on a single view, of course. But let's go a little bit deeper. Let's measure the LVOT. It's a bit faint here, but we felt confident at the time. 2.15 centimeters. Quick math. Area is 3.63. We then carry out a VTI determination from the apical 5-chamber view, and in keeping with the positive pressure state, the patient's respirations, we don't have continuous VTIs that are visible, but we catch a very convincing envelope here. We measure it at 13.4 centimeters, which you'll recall just anything but less than 18 to 20 is likely low. So we can appreciate this patient actually has decreased stroke volume just based on the VTI, but we go through all the motions and we determine that the patient's stroke volume is around 48.6 cc's at a heart rate of 75. This patient's cardiac output is 3.6 liters per minute, falling beneath where we would like it, especially for somebody with vasodilatory shock and somebody with organ failures in a septic state in the ICU. So now we have somebody who, on a 2D fashion, had a heart that perhaps wasn't, again, the culprit problem in terms of the sepsis, but was mildly depressed, and we see that that's resulting in impaired stroke volume. So, and cardiac output for that matter. And so we can then consider our basic physiology and say, well, how would we like to improve the cardiac output? Would we like to improve the stroke volume through manipulations of preload, afterload, or contractility, or do we want to improve or change the heart rate at all? And of course, that will depend on the environment you're in and your skill set. In this case, I think adding a little bit of inotropy might be the most reasonable step. Other people may try fluids. Of course, determining fluid responsiveness is beyond the scope of this discussion. However, that would be up to local practice. Myself, I'd probably add an inotropic agent and see how we do. Repeat the VTI after a couple hours and see if we're on the right track. And so just as a reminder here, we have that stroke volume and ejection fraction, or the 2D assessment of the heart here, is somewhat discordant, as you can see. Once you got the numbers, you realize this heart was really not pulling its weight as much as you might have been fooled to believe based on the 2D images alone. And just as we were speaking of earlier, don't worry about all the math. You can let the machine do everything as long as you input the numbers using the calculation package. So you can input the heart rate, the LVT diameter, and the VTI, and it will come up with the cardiac output for you. So it's important you understand the underlying math and the rationale behind these steps, but leave the heavy lifting in this respect to the machine. Some parting thoughts: the stroke volume and ejection fraction are different. And in resuscitation, stroke volume is way more important. And I hope I can impress that upon you today, and I hope you will find this in your own clinical practice as you begin using this for most patients. Anyone in shock, largely, I'll grab a quick stroke volume anymore. When you first start, it adds an additional bit of time. However, just like anything, as you get more fluent with it, it just comes easily, and it's very easy to include as part of your point of care echo. And as I have alluded to, trending therapies in real time is very interesting. So determining that volume administration does or does not improve your cardiac output, the influence of inotropes, the influence of afterload reduction, the influence of right heart therapy, all sorts of interesting applications that we all do every day to try and improve perfusion. And really at the heart of that, you're all manipulating stroke volume. I wanted to mention, if you're interested in seeing some case examples of point of care echo using stroke volume, we have on our institution's ultrasound website, westernsono.ca. If you go drill down into the learning section, you'll find a hemodynamic series where we have a series of screencasts that cover clinical scenarios where VTI was used. And so you can see how this is applied to very common and some uncommon scenarios where shock was at play and doing a stroke volume determination added value. With that, I thank you for your time and attention. I hope the screencast is useful for you. We'll talk to you again soon.